Good afternoon. I'd like to thank SAGES for having us today to discuss our research. I have no disclosures. As we know, the COVID-19 pandemic brought demonstrable strain on healthcare systems and resources. We saw nursing shortages and supply scarcity. Due to uncertainties of patient safety, we also noted decrease in number of patients presenting for non-COVID related complaints in our emergency rooms and waiting rooms. Questions regarding physician safety impacted management decisions, including recommendations for non-operative management in cases that may have classically been operative. We initially sought to evaluate the effect of the COVID-19 pandemic on the acuity of cases that we were observing, the resultant management of those cases, and how that impacted our outcomes. Following our initial evaluation, we delved into what may be causing our observed outcomes and wanted to investigate whether the implementation of a dedicated EGS service helped to mitigate some of the unforeseen strains brought on our hospital by the pandemic. We performed a retrospective study at a single tertiary care hybrid community and academic institute that serves the majority of central Iowa with a fully ACGME accredited residency program with 900 plus beds and performing over 7,000 emergency general and vascular surgeries yearly, which included 381 cases of acute appendicitis occurring over a 2-year period beginning January 1st of 2019 and ending December 31st of 2020, with our pre-pandemic period being defined as all cases occurring prior to March 1st of 2020. Now to quickly go over some of our baseline demographics, most of our patients were middle-aged and evenly distributed between males and females. A majority of our diagnoses were of uncomplicated appendicitis, with 40% being complicated, and 30% of our patients had Charlson comorbidity index greater than 3. This table summarizes the interventions that were offered, including appendectomy, bowel resection, operative drainage, and then interval appendectomy preceded by any form of treatment prior. Our predominant modality was laparoscopic. Our mean operative time was 58 minutes, and 35.4% of cases were classified as dirty. Analysis of the pre- and post-COVID cohorts revealed a significant decrease in the number of uncomplicated appendicitis, with a decrease of 15% in the post-COVID period. We performed less appendectomies and less bowel resections in the post-COVID period, as well as more interval appendectomies. Despite seeing more complex cases, our operative times were actually shorter, which was nearly significant, and we did note a significant increase in dirty wound classes. Surprisingly, despite there being more complex cases and more dirty wounds, our postoperative complications were significantly decreased. There was no significant difference in major morbidities, ICU admissions, or reoperations. However, we did note a decrease in length of stay in the post-COVID pandemic, which was near significant, and we also noted that fewer patients were discharging somewhere other than their home in the post-COVID period. So, following this initial analysis, we had to ask ourselves, why are we seeing significantly increased numbers with complicated appendicitis and dirty wound classes, but not observing other expected associations like increased length of stay or increased operative time or increased postoperative complications? So we knew initially that one of our confounding factors of this study would be the implementation of a dedicated EGS service that occurred on July 1st in 2019, and that included 90 cases that occurred prior to that event. So our first step in sub-analysis was to exclude those cases, and then we evaluated the pre- and post-COVID cohorts only during the EGS period. We still observed a decrease in uncomplicated appendicitis. We had similar findings to our initial analysis in operative management and in number of non-operatively managed cases, as well as a similar trend in significantly dirtier wound classes in the post-COVID period. Our postoperative analysis was a little different from our initial analysis in that, although we did trend towards significance in decreased postoperative complications, this was no longer significant in the post-COVID period. We also noted that fewer patients were still discharging to places other than their home, but most interestingly, we noted that there was now no difference in length of stay when, as we recall, observing the entire cohort, this was a nearly significant difference. So again, we found this interesting and wondered if this may be related to the presence or absence of our EGS service itself. So we performed a second sub-analysis excluding all of the post-COVID cases and then analyzed only the pre- and post-EGS cohorts. Not surprisingly, we didn't find many significant differences between the acuity of cases or interventions, operative time, or wound class. We did note that there was a trend towards decreased postoperative complications after implementation of EGS, and most notably, we now demonstrated that there was a significant decrease in length of stay after the implementation of our EGS service. So as we've discussed throughout, there were paradoxical findings. We saw a decrease in discharges to facility, which we speculate may be related either to patient preference to not remain in facility during the pandemic or a scarcity of facility availability during the pandemic as well. We saw a decrease in postoperative complications and decreased length of stay, which initially we thought may be related again to patient preference for earlier discharge or possibly supportive of some of the evidence regarding non-operative management of acute appendicitis. However, following our second sub-analysis, at least at our hospital, we think it may be more related to the presence or absence of our EGS service. Some of our limitations include subgroup analyses, but our findings remained evident throughout. And then our major confounding factor, which ended up giving us sort of a unique opportunity to see the interaction between a new EGS service and an unforeseen stressor on our hospital. So to conclude, the COVID-19 pandemic was associated with increased rates of complicated appendicitis, dirtier wound classes, and increased rates of non-operative management. Despite this, we observed decrease in postoperative complications, decrease in discharges to facilities, and decrease in lengths of stay. We speculate that some of our outcomes may have been related to the creation of a dedicated emergency general surgery service, and I think this was a unique and kind of happenstance opportunity for us to see how the systems-based management of these cases can actually help mitigate the strain of stressors that are unforeseen on our hospital systems. Thank you.